Hello, thank you very much for joining today. Nice to meet you, Professor.
To
Hi,
meet
Professor
you.
Lau.
Yes, great, great, great. And thanks for coming.
Thank you for the
You are
invitation, Professor.
Dr. Wong is now in
Thank you
Singapore,
very
am I
much for
correct?
joining today.
Yes, that's right.
Thank you.
That's good, wonderful. I have been to Singapore twice already, recently. APWF, and also the ESMO, Antec. All right. It's a very good study. Congratulations. It's highly cited.
Thank you,
So
Professor Lau.
we only select those highly cited as a token of thanks and appreciation. So, and I think that's it's important because it's all tape recorded, and you can always come back to the presentation. So you work with Mingo.
Yes, that's right.
So you were trained in Stanford.
Well, I was working in the area of Hep C, so we worked together
Uh-huh.
in the Real C Consortium with Professor Mindy.
Uh-huh.
So she
Okay,
was
good.
the kind of like my mentor for this project. So
Uh-huh. Okay.
yeah,
So where are you stationed now?
I'm now
Let's
in
see.
the Changi Hospital.
Oh yes, Sing Health.
That's
Is it
right.
Sing Health, Singapore? Okay, all right. Changi. Oh yes, of course, Changi General Hospital is very famous one. Yes, I can see that. All right. Um. So we have 9 more minutes to go. You can take a rest, and all the slide sharing is already done. Assuming you have all the slides ready with you, or who is going to upload the slides after when the meeting starts?
Could you please share from your side, sir? Professor Wong?
Yes, I
Ah,
can share from my
so
side. No
Okay,
problem.
thank
okay,
you.
all right. So I will come back in 5 minutes. Thank you.
Thank you, sir.
Thank you, Professor Lau. Thank you.
So, thank you very much for joining today. And if possible, may I have your slide for just in case?
Oh,
Or,
yes, sure.
could you please
Uh,
now test to share from your side, sir?
no problem. I will
Thank you so
start
much.
sharing it now.
Thank you so much.
Would you be able to see the slides
It's coming. Oh, yes. Yeah.
with APASL webinar?
Yeah, we can see. Yes, Professor Ninchi. Thank you very much for joining, Professor.
Should
So
I
here.
stop share now? It's
Oh,
me.
yeah, sorry. Can you move it to forward just for in case? Could you click
Forward.
slide?
Oh
Could you
yeah,
show
just
the next slide, sir?
like this.
Oh, yeah. Yes, we can see it very clearly.
Oh,
Thank you so
was
much.
I
It
will
seems
stop share for now. Thank
yes,
you.
thank you. And at first, we'll show the short poster on the beginning. So please just wait 30 seconds. And then after that, maybe Professor Joshua will introduce you. And then here's Professor Ninchi. She's a panelist. So
Hi,
thank you
it's
very
me.
much.
Good
Thank you.
afternoon.
Good evening, ma'am. Thank you very
Yeah.
much for doing this. So
Hi,
here,
Professor Ninchi. Nice meeting you.
Hi, Dr. Wang. Yeah, good to see you. Thank you. So we will start in 5 minutes.
yes, ma'am.
So I think I will be the moderator for the second.
Yes, but unfortunately, I have one speaker, just Professor Moon.
Oh,
And
just one speaker.
yes, so
Oh, good.
if
Okay.
Professor Lindon, you were coming together to be a panelist, and maybe during the discussion, could you please introduce?
Yeah, I can moderate. And I see Professor George Lau is also online.
Yes, sir. Yes, ma'am.
So he will introduce.
Yes, ma'am.
Yeah,
I-
good. Good. Sounds good.
Sorry,
you
can I
very
ask how long is the discussion? Because my presentation is probably about 50 minutes.
Yes.
Well, it
So
depends.
60 minutes.
originally,
Do
well,
we get questions from like online audience? Do we get audience,
yes,
online audience?
we should have some audience from the online. So
Yeah. So
maybe
do
we
they ask questions?
yes, they will ask the questions
They will
through.
ask questions. So it depends. And but usually maybe like 15 minutes for discussion? I don't know.
Yes,
Eh,
15 minutes.
Hi.
Hello, Professor.
You need to unmute.
Hi, Professor Domichi. Nice meeting you.
Yeah, you need to unmute, Professor Domichi. We can hear you.
Yeah, I'm so
Yes.
glad to see you. Yes.
Yes, good to see you
How are
too.
you, Professor Kim?
I'm good. Thank you. Thank you. I'm good. It's getting to the holidays seasons. So
Good.
this is the last activity for 2025, I guess, for APASL, right?
How about
Yeah.
Professor Wong?
Oh, it's great. It's great. I'm actually having vacation in Bangkok right now.
Oh, oh,
Very nice. Very
Yes,
nice.
yes. Thank you so much for the very kind opportunity to share our work. This is really a true honor. You know, it's very hard to get a paper accepted in Hepatology International, let alone being selected. So, on behalf of the team, we really wanted to thank the APASL for the opportunity to share our work. Thank you so much.
Thank you. 泉さん、元気ですか？
はい、元気です。ありがとうございます。
どうも、どうも。
ありがとうございます。
はい、はい。
今日もよろしくお願いします。
どうもよろしくお願いします。
So, maybe Professor Joshua is coming back soon. So, would you please wait a moment? Thank you so much.
Hello, Kada.
Hello, George. How are you?
How is the meeting going on?
Everything okay?
Yeah, I will try to work out our support from our side later on. Too busy.
We are concentrating very much about organizing 2026 APASL Congress.
It's very important, and I think that I hope there is a lot of tensions recently, geopolitical,
Yes.
which is really unnecessary, and the U.S. bombed the Thailand bomb Cambodia bomb.
Yeah. I hope you can stay more and you can travel some places in Turkey.
Well, I'll certainly come over. It's a very nice place, and this will be the first time to try the new airport.
So, it's almost time. May we
Yes,
open the door
yes,
and
yes.
show the e-poster
Yes.
from now?
Yes,
Thank
yes.
you very much.
Professor Omata said he will come in later. All right.
Okay.
Professor Ling Qing is here. Wonderful. Yeah,
Yes,
maybe
we have been waiting for you.
Professor Ling Qing to moderate the sessions because Professor Wong is from Singapore and it's a very big group about hepatitis C, the real C study. So we have one paper selected. I think this is highly cited, this one. Yeah, 林前可以吗？
Now
Yes, 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 please go
Yeah,
ahead.
okay, yeah, okay, great. You can start. Welcome everybody. I'm George Loud from Hong Kong, and today we have Professor Ling Qing to moderate the sessions, and we have selected one of the best paper published in Hepatology International's highly cited entitled "The Real World Treatment Outcomes with Protease Inhibitors DAAs in Advanced Hepatitis C Cirrhosis, a Real C Study." And Professor Ling Qing, can you take over the chair?
Yes, thank you very much, Professor Lau, for your kind introduction. And it's my honor and a pleasure to moderate this selected paper presentation. And we are glad to also have Professor Domisi to be one of our senior clinicians and scientists to join us for later discussion. So due to the time consideration, maybe we just go directly to hear Professor Wang's presentation. Could you start? Thank you very much. Can you?
Can you see my slides?
Not really.
Oh,
Yes,
okay.
we can see
Show
a
your
slide.
screen.
Yes, it's
Can
here.
see?
Yes.
Not
This is not
my
your slide.
slide.
This is the title page.
Yes.
You have to show your slide.
This is the slides.
Yes.
Yes, we are fine now.
Okay. All right. So thank you very much, Professor Nishi, Professor George Lau, and also Professor Domichi. And first of all, my name is Eugene Wong from Changi General Hospital, Singapore. And on behalf of our team from the RESI Consortium, really I would like to thank the APASL committee for selecting our papers and giving us the opportunity to share our work at this meeting. And this is really a prestigious and honor for us. So the title of our work today titled "The Real-World Treatment Outcome of Protease Inhibitor (PI) versus a non-PI direct-acting antiviral in decompensated HCV cirrhosis patients." This is a study from the RESI Consortium, and our corresponding author is Professor Minnie Nguyen. So these are my disclosures, and this study has been presented as oral presentation at ASLD 2022 as well. So as a background of our study, we know that approximately 57 million people currently are estimated to be chronically infected with hepatitis C globally. Although we have a very good treatment, direct-acting antiviral achieving 95% and beyond success treatment rate in this group of patients. However, the treatment among decompensated cirrhosis patients remains limited, and current guidelines discourages the use of direct-acting antivirals containing protease inhibitors in this group of patients, mainly from the concern of worsening liver functions because of a reduced drug clearance in decompensated cirrhosis patients. While ideally, liver transplantations is a perfect treatment for decompensated HCV-related cirrhosis patients, but we know that in the real world, patients that is successfully undergoing liver transplantation are very limited, and only a small proportion of patients that are able to undergo liver transplantations due to financial and social circumstances. Therefore, we thought that having a better understanding about the safety and efficacy of PI-based DAA in decompensated cirrhosis patients will be very relevant. Prior to this, study has also looked at the safety and efficacy of a PI-based DAA amongst compensated cirrhosis patients and has shown to be efficacious and safe. However, the data in decompensated cirrhosis patients remain very limited. Therefore, the current study aims to investigate.
Sorry. Okay, now it's processing.
Yes.
Yeah, it's
So
fine now.
thank you very much. So the current study really aims to investigate the real-world tolerability data of PI-based DAA in decompensated cirrhosis patients. This is a multi-center, multinational retrospective registry coming from the REAL-C study. The REAL-C stands for Real-World Evidence from the Asia-Pacific Liver Consortium for Hepatitis C. And this is the study was mainly coordinated in the Stanford University in the United States of America. At the point of analysis, the REAL-C consortium collected data from 27 study sites. You can see coming from not just United States and Europe, but also from many places within the Asia Pacific regions, including Singapore. So in terms of our study methodology wise, this retrospective observation, cohort study included patients treated with direct acting antiviral in the real world settings between 2014 to 2021. We included only adult patients with hepatitis C decompensated cirrhosis who treated with direct acting antiviral. For the purpose of this study, we defined decompensated cirrhosis as having a history of clinical decompensating events at least 6 months prior to DAA, or patients with a baseline Child-Pugh score more than or equal to 7, or those with a MELD score of more than 10. And our primary outcome is to look at the proportion of patients with significant worsening or improvement following the DAA. In these studies, we defined significant worsening or improvement as the change of at least 2 points in the Child-Pugh score and MELD score in these patients. Our secondary outcome is then to look at the SVR12, SVR24, and any occurrence of new liver-related events, including clinical decompensations, hepatocellular carcinoma, and death. This is the study flowchart from the initial cohorts of more than 15,000 hepatitis C patients treated with DAA in the real-world settings. We identified more than 5,000 liver cirrhosis patients. After excluded patients without prior decompensating events and patients with missing data for analysis, we included about 1,077 patients with decompensated HCV cirrhosis for our analysis. This is the baseline characteristic of the study. You can see that about 45% of the patients were treated with a PI-based DAA, while the rest were treated with non-PI-based DAA. You can see that in the unadjusted cohort, the PI-based patients are generally older, more likely to be genotype 1, and more likely to have renal impairment. Furthermore, the PI-based DAA, although they have a lower Child-Pugh score in general, but they tend to have a higher MELD score, right? And patients with non-PI-based DAA tends to have a higher proportions of having the prior clinical decompensating events. So because of the differences in the baseline characteristic, we proceed by matching the both cohorts before running the analysis. And we can see that even after adjusting to the baseline characteristic, now we can see that both cohorts of patients with PI versus the non-PI based DAA are now comparable in terms of their age, gender, and their genotypes. And about a third of patients having prior treatment history. And both cohorts are now also comparable in terms of their baseline comorbidities such as diabetes and also chronic kidney disease, which is now balanced, unlike before matching. After matching, the Child-Pugh score is now comparable between the groups, although the proportion of patients with a MELD score less than 15 are comparable between the two groups. Still, after adjustment, there's a slight differences with a PI-based DAA still having a higher number of patients having very, very high MELD score, more than 20. The proportion of patients with clinical decompensations is also comparable between the two groups, and both groups were also similar in terms of their baseline laboratory results. This is the types of DAA used in this group of patients. Among the patients treated with a PI-based DAA, the commonest use of DAA are the Vicaria pack. And in the non-PI-based DAA group, the commonest use of the DAA is sofosbuvir and ledipasvir. This is a change in terms of the Child-Pugh score and MELD score between the PI versus non-PI based DAA over time. You can see that from the baseline to SVR12 and SVR24, both groups has a slight decline in terms of their Child-Pugh score over the time of treatment. And the same goes to the MELD score as well. Both groups have a slight improvement in terms of the MELD score over the time of treatment, and the improvement is seen in both PI versus non-PI based DAA. This is the clinical outcomes between patients treated with a PI versus non-PI based DA at the point of SVR12. We can see that the SVR12 was similar. Importantly, we can see that the proportion of patients achieving the significant improvement are similar between the patients treated with a PI versus non-PI based DAA. Although there is more patients with a PI based DAA having a significant worsening, but the number of patients have experiencing the liver decompensations or liver-related death were similar at SVR12. By the time of SVR24, we can see that a similar trend at SVR 24 were the same between the PI versus non-PI based DAA. Proportion of patients with a significant improvement, number of patients with a liver decompensation and liver-related death are similar between the patients with a PI treated with a PI versus non-PI based DAA. And then we look at the clinical outcomes stratified these patients based on the Child-Pugh class, knowing that the Child-Pugh class A patient generally has a slightly better outcomes. These subgroup analysis, especially looking at patients with Child-Pugh class B and Child-Pugh class C, we can see that among these patients who have a Child-Pugh class B and Child-Pugh class C, there is no significant difference in terms of the clinical outcomes, in terms of the SVR, liver decompensations, patients achieving significant improvement or worsening between PI versus non-PI based DAA. We also further looking at the clinical outcomes stratified by MELD score. Most patients had now in our study has a MELD score less than 15 or less than or equals to 15. We can see that in this group of patients, the clinical outcomes are comparable between patients treated with a PI versus a non-PI based DAA. The clinical outcomes among patients with those with MELD score more than 15 were also comparable, but I would like to highlight that this group of patients with MELD score more than 15 are generally much smaller within the cohort itself. Therefore, the interpretations should be taken with cautious. We also further do subgroup analysis looking at those patients with previous clinical decompensations versus those patients without clinical decompensations. Again, we see the similar trend that patients treated with a PI versus non-PI based DA has comparable outcomes in terms of SVR12, liver decompensations, and proportion of patients achieving clinical improvement following DAA. In terms of the clinical outcomes, we also compare the types of DAA, the first generation versus the second generation DAA. Again, we see that the clinical outcomes for patients treated with a PI versus non-PI based DAA were comparable between the two groups. The strength of the study is that this is to date the largest multi-center, multinational cohort evaluating the safety of PI-based DAA among the hepatitis C decompensated cirrhosis. These studies also shows that the practice really reflects the real-world practice, whereby even though PI-based DAA was not recommended among decompensated cirrhosis patients, in the real-world settings, sometimes clinicians still have to resort to use PI-based DAA in this group of very sick patients. And this study adopted a very robust statistical analysis by using the IPTW matching to adjust for the baseline differences between patients treated with a PI versus non-PI based DAA. Our study also included a wide range of patients with a different hepatitis C genotype and DAA regimens, which will help with the generalizability of our findings. But nevertheless, our study is not without limitations. We'd like to highlight that this is a retrospective study, so there will be inherent selection bias where physicians may choose to avoid PI-based DAA among sicker decompensated cirrhosis patients. Second, in regards to the definition of decompensated cirrhosis patients, we included some of the Child-Pugh class A patients with previous clinical decompensating events in this cohort. Nevertheless, when we run the subgroup analysis, specifically looking at patients with Child-Pugh class B and C, we see similar results showing that the outcome between the patients treated with PI versus non-PI based DAA remains the same. And finally, I would like to highlight that the subset of patients with very severe decompensated cirrhosis, these are the patients with Child-Pugh class C, MELD score of 15 or more are small. Therefore, the interpretation of data in this group of patients has to remain cautious. So, ladies and gentlemen, dear friends and colleagues, to conclude, in this large multinational real-world cohort of diverse patients with decompensated HCV cirrhosis, we found that there is a similar rates of clinically meaningful worsening in Child-Pugh score or MELD score in both patients treated with a PI versus non-PI based DAA at post-treatment week 12 and week 24. We also found similar frequency of new clinical decompensating events and death among patients treated with PI versus non-PI based DAA in these patients. I would like to take this opportunity to acknowledge all the participating centers for contributing their data. And importantly, I would like to thank our lead PI, Professor Mindy Nguyen from Stanford University on the left. On the right, you can see the Sally. She's a lady in the black skirt. She is our co-PI, who I have a great honor collaborating with her together with Professor Mindy in these projects. And with that, we thank you very much for your kind attention.
Thank you. Thank you very much, Professor Wang, for your kind invitation. Could you please leave your slides on, especially the last, no, the one before last slides, the conclusion slides. Yes. So you let me start, and then I will hand over to Professor Yu to moderate the discussion session. So congratulations for this wonderful study with the largest cohort for the multicenter hepatitis C decompensated cirrhosis patients with the goal to compare the PI-based versus the non-PI-based treatment. I noticed that you have the longest is the 24 hours post-treatment, 24 weeks post-treatment to compare the efficacy and safety, right? Do you have longer follow-up durations for these kind of patients? Have you considered working on that?
Thank you very much, Professor Nishi, for the questions. For the purpose of this study, we only look at patients with a follow-up up to 24 weeks because a follow-up beyond 24 weeks, the number become really very small, and that limits the power of the analysis. So we have not able to look at the long-term outcome among these patients treated with the PI-based DAA beyond 24 weeks.
I see. Okay, so thank you. Professor Yu, please. Maybe we have some questions from the audience, or yeah, please.
Yes, this is an excellent presentation. This is Joshua from Hong Kong. In fact, it's a multi-center study, including several sites here in Hong Kong too. Now, you make IPTW the match control. I just wonder why you do not try to balance the treatment naive group, and also you do not balance the MELD less than 10 and make it a significant difference between the PI-based and the non-PI-based treatment group. I think this is my first questions about the methodology, and I would like to follow up with another questions of the really the significance of this paper, because we know that in the guidelines currently it is not encouraged to use PI-based therapy for liver functions. But whether your study is powerful enough to allow us to include PI-based DAAs for this subgroup of patients.
Thank you, Professor George Lau, for the very important questions. The first question pertaining to the methodology of adjusting for the MELD score. And actually, we did try to match it according to the MELD score, but because of the baseline characteristic between the two groups are pretty different. So even after matching, there is still some differences, especially at the extreme group beyond MELD score of 15, because this group of patients and number are really small. So I hope that answered the questions. I think importantly, rather what is the clinical implication of this study is that actually the study shows that if you have a MELD score of less than 15, which is a majority of the cohort, we found that the clinical outcome are similar. And most importantly, about a third of these patients following treatment, they achieve clinical improvement. And at the same time, the safety concern was addressed in a way that both group are largely the same. And in our opinions, we feel that patients with decompensated cirrhosis is a huge range of differences. They can have patients who have very mildly decompensated patients, especially those patients with MELD score of 15 and below. Perhaps these patients, if the access to liver transplantation is limited, it is reasonable to consider PI-based DAA in these patients, because this could represent an opportunity of cure and opportunity to improve their synthetic functions. Whereas in patients with MELD score of 15 and beyond, we will like to advise for cautious when interpreting these findings, because the cohort of patients with MELD score of 15 and beyond are relatively small. And ideally, this patient with a MELD score of 15 and beyond, they really should consider liver transplant as a first-line treatment.
Sure. Well, because in China we do have a lot of hepatitis C, and I'm sure Professor Ling Chen has a lot of experience. And you have only a few hundred patients, and for your, I think it's because of the samples and also the characteristic of the samples being collected, you are restricted in certain areas. I think this is a very good study. But then it follows my next questions is, does it really help in our management? Since now we are using, because it was not mentioned in this paper, whether generic is all involved or you are not using the non-generic one, because nowadays, 10 years down the road, especially in China, I think that Professor Ling Chen will make a comment afterwards. So the generic is so much cheaper and it's so widespread in Asia Pacific region, especially China, India, and Pakistan, and so on. And I would like to hear the comments from the panelists and also the moderator and the authors yourself about these very important practical issues.
George Lau, may I speak?
Yes, yes, please.
Yeah.
In Turkey.
Thank you very much. Thank you. Actually, the clinically worsening and also mortality days related with the post-treatment periods. In the conclusion, I would like to ask, how can you explain these similar rates of clinically worsening in CTP or MELD scores at both post-treatment week 12 and 24? This is my question.
The question whether why is the rate remains similar in both group. I'm not quite sure whether when we look at these findings, we only include patients with data available, and it's interesting which we also agree that one would expect that there may be more patients having clinical improvement and worsening at week 24, but we do not observe a significant difference. And perhaps following what Professor Ning Chi has highlighted earlier, perhaps with a longer term to follow up, say up to 1 year and beyond, we may see a higher proportion of patients achieving clinical improvement or achieving what we now call recompensations following treatment in this group of patients. Thank you for the questions.
Thank you.
Well, this is exactly actually follow my questions about the MELD patients with more or less greater than 10, because 10 to 15 is the majority of your patients. But then when we go to 16 to 20 and greater than 20, the numbers are really getting very small. And that's the reason I think that, and also you haven't answered my question whether this is using generic or non-generic medications. And talking about the sample size, I think we can really consolidate and expand the studies to a more solid ground for solid recommendations if we can include more centers, especially from China, India, and Pakistan. This will really solidify your excellent work and give it more strength. Because I'm not sure whether this is having enough power to answer the questions of the compensated liver disease in the studies, because that actually is the number is really pretty small. 16 to 20, 35 to 13, and 22 patients.
Dr.
So it's
Mang or George, this is Dr.
yes,
Mata
yes,
from
Professor
Tokyo.
Martin, please.
I was being here for the very beginning, and I listened this wonderful talk. The question is, I think this is a very significant study. So, as George said, whether we should revise the guidelines or not, because since George brought the matter of the generics, so that makes things totally different. But we are in the scientific field. So, how do you think, Dr. Wang, this can change, possibly change the guidelines? Because as was mentioned in the guidelines, in most of it, we cannot use a PI in the decompensated cirrhosis. What's your opinion?
Thank you, Professor
Mata.
Omata, and thank you, Professor George. I will first address the Professor George questions because this is the second time Professor George is asking. For the purpose of this study, we did not distinguish between whether patient is treated with a generic or non-generic DAA. So we don't have that data at this point of time. But agree will be interesting to see, especially in the safety profile, because so far the efficacy data, even with a generic DAA, seems to be comparable with the non-generic ones. And second, as to whether the findings should be incorporated into the guidelines, as author of the paper and on behalf of the group, we think this is a reasonable considerations because prior to this is a strict absolute contraindications to even consider PI-based DAA in the decompensated HCV cirrhosis patients. There are some patients that have limited access to liver transplantations, and those patients with perhaps very mild decompensated HCV cirrhosis, Child-Pugh class A, just with one episode of variceal bleeding, very low MELD score. Is it reasonable to consider PI-based DAA? And our data seem to support that in the selected cases, these patients, if you consider PI-based DAA, will be reasonable because these are the patients that either the access to liver transplant will be limited, or these patients even listed on the transplant wait list, they might never going to receive a liver transplantation for a long period of time, rather than not giving them any treatment, which have a 30% chance of cure and more than 90% chance of cure and 30% chance of clinical significant improvement. We thought this is reasonable to consider in the guidelines, perhaps to say that in the case-by-case basis, perhaps the PI-based DAA can be considered.
If this data came 5 years earlier, we may have to consider. But as George mentioned, in real world data, they are using a lot of the generics. So maybe, unfortunately, 5 years late.
Well, I think this is very important studies. But what I'm trying to say is the number involved is still pretty low. Taking into considerations, we have much larger numbers, and if you can work through APASL's members countries, I'm sure you can recruit more patients just focused on poor liver functions and decompensate the liver functions with couch Bs and so on, so that we will be more focused. That's what I'm trying to say, rather than having a large numbers, but only less numbers is involved in this category, so we can have a better understanding. Especially now we have transplant service. This really should focus on those centers with transplant service because I think they have more decompensated cirrhosis to take into as a clinical experience. And the largest transplant centers in the world, I think, is now China and also India. We just have a single topic conference in Qingdao, and they in China we are doing 5,000 liver transplantations, and in India another 5,000. So, and also now we have also Japan and Korea come in, and I think that the society will support to have a very good and solid studies which can revise our guidelines for hepatitis C, and I think we are in a very good position if this would be
Ninchin
considered.
or MLU, I want to have your opinions on matter.
Okay.
Yes, Dr. Yu. Hello.
Yeah, Omura Sensei. Good afternoon. So I think this study provided some very helpful, significant real world data for the PI-based DA in the treatment of cirrhosis, especially some patients with decompensation. I think it's not the routine candidates right now. So most of the patients with PI-based therapy for the cirrhotic, especially the decompensated cirrhotic patients, it happened to be earlier years at the time the sulfoxaflor-based therapy are not available in most of the countries in Asia. So I think this study, although it cannot change, I think it cannot change the current clinical guideline, but it also provided some evidence that this PI-based regimen have a comparable efficacy and also comparable safety in a small population of decompensated patients. However, the limitation of this study is that the first, this study did not have the data of patients who early terminated from the PI-based regimen. I think it's very important because the most important issue that we are concerned for PI-based therapy is the drug interaction and the hyperbilirubinemia due to the protease inhibitor. And some of these patients we are terminated early from the DA therapy. So I think we have to address these key points. That some patients will also experience decompensation with the PI-based therapy, especially in the common cirrhosis patients. Yeah.
Thank you very much.
Yes.
you.
That's the reason.
Ninchin from China.
Yes.
Lady from China.
Thank you, Professor Mata. Yeah, I also like to say a few words. This is a very interesting study, and the original idea, I think, is to explore whether the PI-based regimens can be applied in decompensated cirrhosis HCV patients. So I think the rationale for this study is quite clear, and also it provided some insight for us to understand that even PI-based therapies could be applicable in this group of patients, although the final enrollment of these patients' numbers are not, I think it's not large enough to provide a confirmed evidence to change the clinical practice guidelines. That's my key. I mean, my main opinion on this study.
Thank you. The reason I'm asking you is because we made a guideline to APASL. So I think this may be influential in terms of the guideline, but I think a little bit late to modify that. So in the real world, it's maybe already seems that. So
right.
Yes.
But at least we are not that afraid of PI-based therapy in certain cases in the selected patients. If we do not, if there is not available of non-PI based regimens available.
Okay. Thank you very much. Yes. Good. So George, go ahead.
Well, I think this is an excellent study. We want solid data. As I mentioned, we need to have more patients, and especially when I'm echoing with Professor Eugene Long, because there's PIs, we are afraid of drug-drug interactions, and we need to include these elements into the studies to really make a change. I think it's still useful, even if we have generics, because this is science. We have to make decisions based on science and also availability and affordability. So sometimes in these very sick patients, we have other medications coming in, and this needs to be included into the studies to have a good understanding. And talking about the numbers, so I think that the collaborations is of utmost importance, and we can learn a lot from a very good initiative like the AHOC. We collect data, and this will be important because nobody is doing this anymore, having the initial drive for hepatitis C. But I think for our patients, this is still very useful and meaningful studies. And congratulations to the group.
Hello, Dr. Wang. Can you hear me? I have
can hear
one
you,
question.
Professor.
This is Tatsuo Kanda. You collaborate with several Japanese researchers. In general, we use only non-PI based therapy for decompensated cirrhosis. Which country did they use PI based therapy in your collaborator?
Thank you very much, Professor Tetsuo. I think I don't have the data on whether which country that uses that contributed the most PI in our cohort, and you're right that not all the countries actually uses PI-based TAA. In Singapore, the data that we contributed I would say that I echo what you say. The proportion of patients receiving PI-based TAA is actually relatively small because we use Softval as a first line treatment. We have a long-standing good experience with Softval, and many of the PI were the early generation. So Vicirapact is commonly used. So they're actually coming from all the participating sites, and they may not be limiting to just Japanese sites alone. Yeah, meaning the same site may have contributed either data on the PI or non-PI based TAA, as long as the site has contributed to decompensated cirrhosis patients in the registry.
Thank you very much.
Thank you, Professor Tatsu.
Well, very good discussions. We are
Yes.
talking about the real world data. Yes, good, wonderful.
Well, I think this is a very good initiative, and I hope that we can have more groups to join in with this type of studies, especially for hepatitis C. I think the burning questions is now for the post-eradications, HCC surveillance, and so on. So this will form a very good cohort. We can follow up these patients and expand the cohort with the drive of the viral elimination task force and with the support of APASL. There will be lots of other data coming up too. I think this can form a database and I think that Professor Wang is still very young. He has a long time to follow up those patients for the outcome. Actually, that was brought up by some of the panelists. I think it's Professor Yu and Professor Ling Chen brought up the outcome of these patients, which is also very, very important. So congratulations. Any final comments from the panels? Professor Thomasy, Professor Obi is here. Professor Obi, you want to make a comment? Okay, and our president Omasi is here. Yes. Yes, our president, can you say a few words? And should we have expanded studies to be presented at your coming annual meeting for this
Yes.
important piece of work?
Of course, it's my great pleasure, Dr. George. In Turkey, as a rule, we cannot give the protease inhibitors for the compensated cirrhotic patients. So I think we don't have experience regarding this protease inhibitors in the patients with the compensated cirrhosis. So this is really a new idea for us. Thank you very much for the speakers and congratulate them. So I think my comment this one. Thank you very much.
Wonderful. So, is there any other further questions? If not, well, we would close this sessions, and I wish you a very meaningful and happy Merry Christmas and a very bright years of 2026. And I hope to see you all in 2026. And our Hepatology International highlights seminars will continue with better papers to be brought up to your attention. So thank you very much.
There is no
Thank you.
topics on the
Thank you very
FGI too.
much.
There is no papers about
Yeah, there's
FGI.
only one. There's only one. Yes.
Okay.
Okay. Thank you
Okay.
very much.
Right. Bye bye.
Thank you. Thank you
Okay,
very much.
so
Okay.
See you.
have a nice
Very much.
Christmas to everyone.
Bye bye.
Thank you
Bye
very
bye.
much.
Merry Christmas. Happy New Year.
Bye
Merry
bye.
Christmas.
Bye
And
bye.
Bye bye. Bye
Happy New Year.
Dogubeji, bye bye.
bye.
Bye bye. Omata sensei.
Yeah.
Yeah.
All
Bye
right.
bye.
All right.
Obi sensei.
Yeah. Okay.
Bye bye.